Welcome to Golden Hour Health and Safety, where we discuss pre-hospital information geared towards EMRs, EMTs, and paramedics of different levels. Today, we're just going to be introducing some general information, some concepts to you. Hopefully, this is more of a review than anything else, but it should help you if you're beginning your career. A quick disclaimer before we begin. This is for information only, and this does not replace your local training, protocols, new information, or research, and is not intended for those not working in, towards, or involved in healthcare. Please always follow your local protocol as well as your own scope of practice. So I broke these into sections and just labeled them in letters to help kind of separate each sort of subject. That way, hopefully it's a little bit easier, and then you can pause at certain points and just kind of remember where you left off a little easier. Patient dignity has a multifaceted approach and involves several factors and unique elements of respect. These things include, but are certainly not limited to, patient autonomy, patient empowerment, patient safety, patient communication, and patient privacy. Throughout this first slide and this first video, we're going to touch on a couple of these things to help you respect your patient, provide them with dignity, and ensure that you're communicating appropriately with them. A good starting point when we're talking about dignity is cultural characteristics. There are many different cultures, and each has specific characteristics that pre-hospital providers should respect. Here are some examples. Some cultures don't shake hands. It would be rude and it'd be inappropriate to do so. So if you see someone and you go to reach out your hand and they don't offer theirs, oftentimes it's not a sign of disrespect, it is a sign of respect. Some cultures don't make direct eye contact, and a lot of cultures and beliefs, looking at the floor, looking away, and not looking directly at you is actually a sign of respect, so we can look at that. Some cultures are taught to not question practitioners or authority figures, so just keep in mind that sometimes that communication, we need to pull out some information from them and let them learn that they can trust us. Some cultures are taught to question many things and ask and get a full detailed report. Some cultures hide how they feel and what is wrong, and some express themselves openly. So just embrace everyone's individual culture and belief and try to navigate that the best that you can with respect and dignity. Patients have the right to protect their privacy in regard to their health and wellness, along with the care they did or did not receive, or the situation that they may have been in. It is our responsibility to protect their privacy and to only share their information with their healthcare team. This is especially important for the practitioner to think of before they share call information with anyone, including social media. And remember that any information is protected health information and you could be liable for sharing it. I do understand that we do have to, as practitioners, debrief calls afterwards. However, all I'm saying is that we shouldn't be sharing details openly. So watch what you say in the public, watch what you say in the grocery store. EMS is a very small community, and when tragic accidents or incidents happen to someone's life, it's usually pretty easy to pinpoint who that was pretty easily. So just consider that, be cognizant of what you say, who you say it to. And when we speak of like the healthcare team that needs to be involved, it means the healthcare team that's involved in the patient's direct care. The person that's stopping the highway traffic, a kilometer down, isn't really entitled to that patient's personal private information. So just kind of consider who you're speaking to and what details you're giving them. Empathy is another really important skill that a paramedic should definitely embrace. So empathy is when you as a practitioner tries your best to put yourself in the patient's shoes and tries to understand why a patient may feel that they would in that particular circumstance. Now, this is very different than sympathy because sympathy involves understanding a patient's situation from your own perspective. which is still important. But if you're able to actually empathize with that patient, you could maybe be able to see the implications of their condition, maybe be able to see why they might be so scared, unsure, nervous, etc. So if you can try to work towards being an empathetic practitioner, you're going to get a lot further with your patients and you'll have a much more holistic approach to your practice. Now, understand that patients are activating emergency services for many reasons, and just try to remember that this is their emergency and not yours. And their emergency is widely defined. We've responded to calls where a person's eye just has an infection and they just can't drive themselves to the hospital because they just had surgery. I've been to calls where the mom needed help because she just didn't have any way to take her 3 kids and herself to the hospital at the same time. She knew it was an emergency as far as life-threatening conditions were concerned, but to her it was an emergency because we were the best resource for her to utilize. So just understand that it's a wide array of people that could be calling you, and it is their emergency, and we don't define their emergency. So respect their sadness, their anger, words and actions, and just understand that it's typically not directed at you. Sometimes you're just honestly the closest person that they are able to express themselves to. This does not, however, give any patient the right to assault you, batter you, or otherwise. And I find that the more understanding that we can be and the more we listen versus we talk and the more we empathize with our patients, the better the situation actually becomes. So in emergency services, we do respond to a lot of folks that are what we call in a special population. So sometimes caring for different demographics can be challenging. As stated before, just remember this is their emergency and not yours. And special populations just are quite varying demographics of people. It's really anyone that you would have a unique challenge. So, for example, myself, I don't speak French. I'm in Canada, but I worked in a very heavily French speaking community. So I found that that was a very special population to me because I needed someone who did speak French to help me translate. I needed to take a family member with me. I needed to sometimes write things down in a different way. So just kind of work around that the best you can. For you, that might not be a special population. You might be fluent in that language or ASL, American Sign Language. So just kind of hurdle over those challenges as you need to individually. These challenges can also be a person that's not from your culture or background, or sometimes this is a person that has special needs. All right, so let's move on to section B. As practitioners, your choice in language does matter. Your tone, your volume, the context, everything does have an impact. So it matters to your peers, patients, and other professionals that you're working with. So just choose your language appropriately to each situation and adapt as you do. Being rude, aggressive, short, or otherwise really honestly never gets to anyone very far. And being demanding, demeaning, yelling, or otherwise does not gain you any respect and does not build trust. I've definitely made these mistakes multiple times in my career, but every time I do so, I stop, I reflect on it. If I need to apologize, I absolutely do, and I learn and grow as a practitioner. There's other courses that you can take called like verbal judo, that sort of thing, that can help you with some communication skills so that we aren't raising our voice and, using swear words and things like that in a very stressful situation as is. So it's just something that you could definitely consider. Communication is honestly key, like we talked about in the previous slide, and it can be quite difficult for sure. So just understand that your patients called you, and again, it is their emergency and not yours. Often patients will lash out, swear, raise their voice, or be very angry. This may be directed at you, but not about you. This is just a stress response, and we just need to treat it as such with respect and dignity, and a lot of explanation of why things are happening. However, I know I've said this before, this does not give a patient the right to assault a healthcare worker. So build a strong, respectful boundaries with yourself, with your peers, and with your patients, and hopefully we can avoid that situation. Okay, that section is complete, so let's jump into section C. How you look matters to patients. I know this seems silly. I know we can dress how we want in our personal lives, but as a professional, we need to understand that we represent something bigger than ourselves when we're responding to families' homes. So keep yourself clean and tidy. Take care of your hair. Avoid perfumes and strong smells due to allergies. Tuck your shirt in. Clean your uniform. Honestly, we're just asking you to look like you care enough about yourself that patients will believe you will care enough about them. Now, there's always disagreement about stretched ears and purple hair and tattoos and all that kind of stuff. All of those things are absolutely professional. As long as they're taken care of, it's clean and tidy, etc., there's no problem with any of those. So that old mindset is kind of out the window. I have stretched ears. I've definitely dyed my hair different colors, and I've never had a problem not looking professional due to that. It's really about the whole picture of your uniform having the respect that it deserves. As long as you do that, you're good to go. So that one's nice and over. Section D, here we go. So, how do we actually approach patients? Um, what's appropriate? What appears hostile? What looks like we're not really listening? So, as I said before, your verbal communication is important, how you look and dress is important, but also your body language is very important. So, a lot of times your body language says more than your words in many, many cases. So, for example, I often usually walk into a room, and if the patient's able, I'll try and shake their hand. It's a normal sort of Western North American greeting. However, if they don't outreach their hand and they don't do that, then I know that that's where their boundaries are because sometimes folks aren't really into that. Sometimes putting a hand on a patient's shoulder can appear supportive and the patient appreciates that. Sometimes that's really not the way we want to go about it. So you need to learn to make slow steps in regards to that physical patient interaction, have a lot of communication. And I always suggest anytime you're going to do something to someone that you need, for example, a blood pressure or otherwise, just say, hey, I'm going to do a blood pressure. Can you give me your arm? Have that patient interact with you. And that's also a really good way of getting consent from the patient for any of those skills that you're requiring to make an appropriate assessment. On to section E. As we talked about before, sharing patient information is absolutely not acceptable, and confidentiality is key. The emergency call that you respond to is the patient's private information. Yeah, theirs, not yours. It means that you cannot share that detailed information on social media, talk about the call with friends or family. This also means, and should go without saying, that you cannot be taking like photographs or video of the situation, and even the details of the patient care report or the details from the dispatch are private. So just think before you share. You can be held liable for any of that. You can be held accountable for things like slander. So just ensure that you're keeping that private. Now, I understand we do need to talk about our calls. That's not what I'm saying. But you definitely do not need to give explicit details around the situation where our small EMS community and our small community around us would know exactly which patient we're speaking of. It's one thing to talk about the situation, to vent about it, to offload that information and get that peer support. It's another thing to be sharing that information as some kind of a pat on the back or, points for coolness or whatever you want to call it out there in the world. And that's what I mean about posting things like on social media or Instagram or Twitter or TikTok or whatever. That is that patient's private information and you cannot be sharing that. We're flying right on by. Here's section F. How well we do our job is also really important. So we need to look at things like quality assurance to ensure that the services that we're providing and the systems that we have in place are actually effective. And you're the ones that are going to be working in these communities and knowing the unique problems and the demographics that you're in. So sometimes we need to reevaluate these things. So these are often called continuous quality improvements or QCIs, which are a really great tool for services to use to ensure quality as well as look into enhancing the services that they provide to their community. A lot of times a quality assurance plan is going to go ahead and identify that there is a problem and it could be a problem with a system, a person, or maybe some interactions with other services. They should be able to conduct a review, so we need to find out the details about this problem, aid the problem, and develop a remedy, a solution to that problem. Then we need to develop an action plan to actually implement that solution that we found. So, like, what are we actually going to do about this problem? We need to then enforce an action plan to ensure that the change occurs. And then once that's happening, we always need to re-examine the problem. Did our solution work? Did the problem go away? And then identify if this is going to be excellence in patient care, and this should hopefully improve. Then after we're done that, look for modifications, any changes that we need to do for this quality assurance plan to actually be effective. And then lastly, we need to always look into identifying other situations that have not already been addressed. So for example, we always had slips, trips, and falls at the local post office. Every year at this post office, we must have responded for at least 20 slips, trips, and falls where there were fractures involved. And it was all because that the water would pool on this ramp that folks would go ahead and walk up and on the stairs. There's no handrails present, etc. So it seems like such a silly thing for EMS to get involved with. But by doing a continuous quality improvement plan and talking to the town, we ended up getting that whole thing restructured. We got handrails put in, a new ramp put in, and immediately the next winter, we noticed an incredible reduction in those slips, trips, and falls for the community. So that's all it really takes, is just noticing that you have a problem in your community and taking the steps to make sure that we have some quality assurance. And then we end up seeing patients are a lot happier, and we have some patient excellence around that as well because we are taking care of them. On to section G. Depending on where you work, EMS awareness really quite varies because EMS in Canada varies greatly from province to province. Some provinces have EMRs, PCPs, and ACPs, whereas others don't actually have any EMRs, but they do have CCPs. Some ambulances are staffed with 2 EMRs or 1 EMR and a PCP or 2 ACPs. It really honestly just depends on local protocol, and that's completely dependent on each province. Regardless, the first line of contact is to dispatch. So from that point, the communication will be dispatched to the most appropriate service for that situation. And again, that system is always going to be varying depending on where you live, where you work, and the system that's in place. Section H. So I'm not going to talk about a bunch of professional associations just because I don't know where you folks are learning from, whether you're Canadian, if you're from the States or otherwise. But I will bring up 3 of them, and these are Canadian specific. So the Canadian Medical Association, or CMA, was introduced in the 1990s for paramedic teaching programs. The Paramedic Association of Canada, or PAC, issued the National Occupational Competency Profile, or NOCPs, to paramedics. And the Paramedic Chiefs of Canada, or PCC, incorporated in 2002 as a national forum for information gathering, development, new policies, coordinating new initiatives, and this was all throughout Canada. So these are the 3 kind of main ones that kind of get together. Now each province also has their own professional associations. There's also individual colleges of paramedics that also speak into this. So it's a quick Google search to find out which one would apply to you, to your country, to your state, to your province. So I'll use Alberta as an example for professional associations and how to get licensed and registered to practice. Now I want to be clear that this was recorded in 2022. So if you're listening to this a few years down the road, the rules in this example might not be applicable anymore. But it will at least give you an idea. So to be licensed and registered to practice in Alberta, you need to do the following. Number 1, you need to partake in an EMR, PCP, or ACP program and get your certificate from an approved organization that is approved through the Alberta College of Paramedics. You need to then write and pass a licensing exam within the Alberta College of Paramedics. Currently, they're using the COPPER exam. Then after that, you'd pay a yearly membership fee, and you'd also have to obtain insurance to actually practice. So those are kind of the 4 main steps. Again, this could change as the years progress, but that's what it is now. Section I. So we only have a few slides left. The second last one is about ethical behavior. So first off, the definition of ethics is the philosophy of right and wrong. And I also like to talk about morality because everyone's got like a moral code, so to speak. So this is a code of conduct defined by society, culture, religion, or person that affects someone's character. And as emergency services personnel, as paramedics, our ethical decisions come into play in some of the following situations where we need to make really tough calls. So, for example, autonomy, which is remember that the patient still has the right to their own health care as long as they still have the capacity to do so. We may have to make an ethical decision on withholding resuscitation or stopping resuscitation. We may have to make a decision when there's a conflict between other healthcare members and ourselves, and in the fact that some people are organ donors or are not organ donors. So we need to make sure that we're always being professional and making ethical decisions. And in the case of paramedicine, those ethical decisions, those right decisions are not necessarily made by us, but as us acting as a patient advocate. So it's kind of a weird line to sit in where we have to be ethically treating our patients appropriately to our scope of practice and to our training. But we also want to be able to work ethically within the realm of the patient's right to their own health care and what they would like to see. It's our last section today, and that's J. So our last slide that we're going to just quickly discuss, and I know we mentioned it before, is patient advocacy. So being a patient advocate is an honor. Our patients are trusting you to have their best interest at heart. So ensure you stand up for your patient and their reasonable wishes and treat them appropriately. If the patient does not consent to a treatment, is confused, or does not fully understand, it is your job to help them digest that information and clear up any questions that they might have. You also have the unique position of being in a patient's home. Other healthcare practitioners don't see that. So being a patient advocate is sometimes more extensive than just you treating that person appropriately or your partner. It also means that when you transfer that patient to a healthcare facility and are transferring that care over, ensuring that the healthcare team there understands the full scope of what you dealt with in that home or in that scene is really quite important. You're the one that sees if their water doesn't run, or they have no electricity, or that's really dirty and unkempt, or it's a hoarding house, or otherwise if it's unsafe for the patient to maybe go back to that place. You can be a patient advocate in a huge way in that circumstance. Your observations are important as long as they're pertinent to patient care and to the health and wellness of your patient. It is important to advocate for those things. So some things to consider for sure. All right, so that's the last little bit of information. So thank you. We really do appreciate the time that you have committed to your education, and we would really love to hear from you. So give us your feedback. Let us know if there's a particular topic within this just kind of general overview information that you'd like us to dive in further or have more questions or would like an individual video about. Let us know which one you'd like to hear about, and we can definitely work with you to create that content for you. Other than that, we really appreciate your time and happy learning.